Perioperative nursing care includes care that is provided before, during, and after surgery. Surgery takes place in a variety of settings, including hospitals, surgical centers that are attached to hospitals, and healthcare providers' offices. A nurse working within the perioperative setting must be able to respond to complex and changing clinical needs during a crucial time period of a patient's surgical experience. When you work in any perioperative setting, you need to use critical thinking, practice using strict surgical asepsis or sterile technique, communicate effectively with members of the surgical team, and emphasize patient safety in all phases of care. As the length of hospital stay decreases, the educational needs of a patient undergoing a surgical procedure increases. Proper patient and family education is essential to ensure positive surgical outcomes. The types of surgical procedures are classified according to seriousness, urgency, and purpose. The American Society of Anesthesiologists assigns classifications based on the patient's physiological condition, independent of the proposed surgical procedure. The classification of surgery. Seriousness can be broken down versus major or minor, urgency, elective, urgent, or emergency. An elective procedure might be somebody who comes in with carpal tunnel and they're scheduled for a carpal tunnel release. An urgent procedure might be if somebody comes in and they suspect that they've had a heart attack and they've ruled that in and the patient needs to have open heart surgery. This may be a case that's going to be done within a 24-hour period. This is more urgent. Whereas an emergent procedure would be somebody who has an aortic dissection or somebody who has an acute appendicitis. These are emergent procedures. There are numerous factors that create risk for patients facing surgery. Risk factors can affect patients at any point in the perioperative experience. Knowledge of the physiology of the stress response and risk factors that affect patients' responses to surgery is necessary to anticipate patient needs and the type of preparation required. Cigarette smoking by surgical patients is associated with increased perioperative complications, particularly respiratory problems and poor wound healing. Very young and older patients are at greater surgical risk as a result of an immature or declining physiological status. Surgery increases the need for nutrients. Thin and obese patients are often protein and vitamin deficient. Risk of surgical mortality increases as a patient's weight increases, primarily due to reduction in ventilation and cardiac function. Patients with sleep apnea who are to undergo surgery present a significant risk. Receiving sedatives, opioids, and general anesthesia causes relaxation of the upper airway and may worsen sleep apnea. The risk is higher when patients are sedated and lying on their back. Patients have experienced severe apnea and hypoxemia, leading to death following surgical and diagnostic procedures under conscious sedation. Careful screening of patients for sleep apnea is essential prior to surgery. Patients with conditions that can alter immune function are more at risk for developing infections after surgery. A patient who is hypovolemic or dehydrated preoperatively or who has serious electrolyte alterations is at significant risk during and after surgery. Nausea and vomiting affect approximately 30% of patients in the recovery room after surgery. It can lead to serious complications, including aspiration, dehydration, and cardiac arrhythmias resulting from fluid and electrolyte imbalances. Also, a patient who vomits frequently after surgery runs the risk of pulling apart their surgical sutures. Patients most at risk for developing blood clots or venous thromboembolisms are those who undergo surgical procedures with a total anesthetic and a surgical time of more than 90 minutes, or surgeon 60 minutes if the surgery involves the pelvis or lower limbs. Acute surgical admissions with inflammatory or intra-abdominal conditions, and those expected to have significant reduction in mobility after surgery. In addition, patients are at higher risk if they have one or more risk factors. Risk factors include cancer, age older than 60, critical care admission, dehydration, known clotting disorder, and obesity. Throughout the perioperative phase, different nurses and other healthcare providers care for a patient during each phase of the surgical experience. A smooth communication handoff between caregivers is needed to ensure continuity of care and reduce risks of medical errors. Transitions from one care provider to another place patients at risk for injuries, missed care, and errors in translating information. A standardized checklist or protocol for handoff communication between perioperative healthcare providers minimizes these risks. Poor control of blood glucose levels, specifically hyperglycemia during surgery and afterwards, increases a patient's risk for adverse outcomes such as wound infection and mortality. Good perioperative glycemic control has been shown to reduce mortality in general surgery patients with and without diabetes and in cardiac surgical patients. OR nurses prevent pressure ulcers intraoperatively by carefully positioning patients and using pressure-relieving surfaces. After surgery, nurses perform careful skin assessment and intervene using appropriate pressure reduction strategies. Successful critical thinking synthesizes knowledge, information gathered from patients, previous experience, critical thinking attitudes, and intellectual and professional standards. Clinical judgments require you to anticipate the necessary information, analyze the data, and make decisions about patient care. When caring for a perioperative patient, integrate knowledge regarding the patient's specific clinical situation, along with previous experiences in caring for surgical patients. Apply this knowledge using a patient-centered care approach, partnering with the patient and making clinical decisions. The use of critical thinking attitudes ensures that a plan of care is comprehensive and incorporates evidence-based principles for successful perioperative care. A key attitude for a perioperative nurse is responsibility, being responsible not only for standards of care, but being a patient advocate as well. The Joint Commission's 2015 Hospital National Patient Safety Goals include 2 sets of recommendations for perioperative care: infection prevention and prevent mistakes in surgery, such as operating on the wrong patient, operating on the wrong extremity, or leaving a surgical instrument inside somebody. Always review these guidelines within the context of new emerging evidence, agency policies, and the scope of practice of the state in which you practice. The nursing process provides a clinical decision-making approach for you to develop and implement an individualized plan of care. The goal of the preoperative assessment is to identify a patient's normal preoperative function and the presence of any risks to recognize, prevent, and minimize possible postoperative complications. When there is time to conduct a thorough assessment, begin by determining a patient's expectations of surgery and the road to recovery. Listen to the patient's explanation, be attentive, and begin to explain what surgery will involve. By opening an assessment with these types of questions, the patient will become your partner and share the details you need to learn about his or her health. As with any admission to a healthcare facility, include information about advance directives. Ask if a patient has a durable power of attorney for health care or a living will, and include a copy in the patient's medical record. To help ensure a thorough and accurate nursing assessment, electronic health records provide standardized documentation forms for preoperative assessment. Be sure to use all drop-down menus to most clearly portray a patient's history, but also be willing to enter full text descriptions as needed. A review of a patient's medical history includes past illnesses and surgeries and the primary reason for seeking medical care. A history screens candidates for surgery for major medical conditions that increase the risk for complications during or after surgery. If a patient has any surgical risk from a medical condition, surgery as an outpatient may not be advisable, or it will be necessary to take special precautions. Also inquire about a family history for anesthetic complications, such as malignant hyperthermia. Malignant hyperthermia is an inherited disorder, which is a life-threatening condition that can occur during surgery. A review of a patient's past experience with surgery reveals physical and psychological responses that may occur during the current planned procedure. Complications such as anaphylaxis or malignant hyperthermia during previous surgery alert you to the need for preventative measures and the availability of appropriate emergency equipment. Reports of severe anxiety before a procedure identify the need for additional emotional support, medications, and preoperative teaching. Inform the surgeon or anesthesiologist of your findings, especially when you believe medications are indicated. Your knowledge of potential surgical risk factors will enable you to focus your assessment and screen your patients carefully so that you can take necessary precautions in planning perioperative care. Collaborate closely with the healthcare provider when you identify a risk factor that might require therapy. For example, advise patients to consider stopping estrogen-containing oral contraceptives or hormone replacement therapy 4 weeks before elective surgery to reduce the risk of thromboembolism or blood clots. Many hospitals are now making sleep apnea screening mandatory. The Stop Bang assessment tool has high sensitivity and validity. If a patient presents with signs of malnourishment, perform your institution's nutritional screening tool or confer with a clinical dietitian. If the patient has a smoking history, use the information to plan aggressive postoperative pulmonary hygiene, including more frequent turning, use of the incentive spirometer, deep breathing, and coughing. Smoking causes hypercoagulability of the blood and increased risk of clot formation. Provide preventative measures to decrease the risk of blood clots, such as pneumatic compression stockings, leg exercises, and early ambulation. Review whether a patient is taking any medications that predispose the patient to surgical complications. If a patient regularly uses prescription or over-the-counter medications or herbal supplements, some surgeons temporarily discontinue them before surgery or adjust doses. If a patient is having inpatient surgery, all prescription medications taken before surgery are automatically discontinued after surgery unless reordered. If you are in an outpatient setting, instruct patients to ask their surgeons whether they should take their usual medications the morning of surgery. It is important that as a patient moves through different areas, such as from the holding area to the OR, a complete list of medications is accurately communicated nurse to nurse. Allergies to medications, topical agents used to prepare the skin for surgery, and latex create significant risks for surgical patients. Patients with an allergy to certain foods, such as bananas, strawberries, and wheat, have shown a cross-sensitivity to latex. List all allergies in the patient's medical record. In patients who smoke, use information about a patient's smoking habits to plan for aggressive pulmonary hygiene, including frequent turning, deep breathing, coughing, and the use of the incentive spirometer. Habitual use of alcohol and illegal drugs predisposes patients to adverse reactions to anesthetic agents. Some patients experience a cross-tolerance to anesthetic agents, necessitating higher than normal doses. In addition, the surgeon may need to increase postoperative doses of analgesics. Patients with a history of excessive alcohol ingestion are often malnourished, which is going to delay wound healing. Because many women do not know they are pregnant early in the first trimester, many institutions require a pregnancy test when the patient is scheduled for surgery. A pregnant patient has surgery only on an emergent or urgent basis because all of the mother's major systems are affected during pregnancy. The risk for intraoperative complications is increased. Assess a patient's previous experiences with surgery as a foundation for anticipating the patient's needs, providing teaching, addressing fears, and clarifying concerns. Prepare both the patient and the family for the surgical experience. Confer with the surgeon if the patient has an inaccurate perception or knowledge of the surgical procedure before the patient is sent to the surgical suite. When a patient is well prepared and knows what to expect, reinforce the patient's knowledge. Always assess who comprises the patient's family and their level of support. With ambulatory surgery, patients and their caregivers assume responsibility for post-op care. Often a family member becomes the patient's coach, offering valuable support post-operatively when the patient's participation in care is vital. Assess the patient's occupational history to anticipate the possible effects of surgery on recovery, return to work, and eventual work performance. When a patient is unable to return to a job, refer to a social worker and/or occupational therapist for job training programs or to seek economic assistance. Providing patient education about pain reduces preoperative anxiety, which is frequently associated with postoperative pain. Teach patients preoperatively how to use a pain scale so that they can be prepared to rate their pain postoperatively. Surgery is psychologically stressful. Patients are often anxious about surgery and its implications, and they believe that they are powerless over the situation. Family members may perceive the patient's surgery as a disruption of their lifestyle. Experience that it is normal to have fears and concerns. A patient's ability to share feelings partially depends on your willingness to learn, be supportive, and clarify misconceptions. Assume patients of their right to ask questions and seek information. Assess self-concept by asking patients to identify personal strengths and weaknesses. Poor self-concept hinders the ability to adapt to the stress of surgery and aggravates feelings of guilt or inadequacy. Assess a patient's perception of the potential for body image alterations from surgery. Individuals respond differently, depending on their culture, experience in seeing others with alterations in their own self-concept and self-esteem. Encourage patients to express concerns about their sexuality. The patient facing even temporary sexual dysfunction requires understanding and support. Hold discussions about the patient's sexuality with the patient's partner so that the partner gains a shared understanding of how to cope with limitations. Assessment of a patient's feelings and self-concept reveals whether they have the ability to cope with the stress of surgery. The physiological effects of stress are well documented. Activation of the endocrine system results in the release of hormones and catecholamines such as norepinephrine and epinephrine, which increases blood pressure, heart rate, and respirations. Platelet aggregation also occurs, along with many other physiological responses. Be aware of these responses and assist with stress management by offering relaxation exercises. Patients come from diverse cultural, ethnic, educational, geographical, and spiritual backgrounds, which can affect the way each patient perceives and reacts to the surgical experience. If you do not acknowledge and plan for cultural and spiritual differences in the perioperative plan of care, You may not achieve the desired surgical outcomes. Although it is important to recognize and plan for differences based on culture, it is also necessary to recognize that members of the same culture are individuals and do not always hold the same shared beliefs. Conduct a partial or complete physical exam, depending on the amount of time available and the patient's preoperative condition. Assessment focuses on findings from the patient's medical history and on body systems that the surgery is likely to affect. Preoperative vital signs, including blood pressure while sitting and standing, pulse oximetry providing important baseline data with which to compare alterations that may occur during and after surgery, including response to anesthetics and medications and fluid and electrolyte abnormalities. Notify the surgeon immediately if the patient has an elevated temperature. Assessment of oral mucous membranes reveal the level of dehydration. Dehydration increases the risk for serious fluid and electrolyte imbalances developing during surgery. Identify any loose or capped teeth because they can become dislodged during endotracheal intubation or when the breathing tube is put down. Note the presence of dentures, prosthetic devices, or piercings so they can be removed before surgery. Carefully inspect the skin, especially over bony prominences such as the heels, elbows, sacrum, back of head, and scapula. Consider the type of surgery a patient will undergo and the position that is required on the operating room table to identify areas at risk for pressure ulcer formation. An older adult is at high risk for alteration in skin integrity from decrease in epidermis, positioning, and repositioning in the OR. When ventilation is reduced, a patient is at risk for respiratory complications such as atelectasis following surgery. Screen a patient for one or more of the three primary causes of deep vein thrombosis or blood clot, which is known as Virchow's triad. The three causative factors include venous stasis, vessel wall injury, and hypercoagulability. Assess preoperative a patient's usual abdominal anatomy for size, shape, symmetry, and presence of distension. Preoperative assessment of baseline neurological status is important for all patients. The baseline neurological status assists with the assessment of ascent or waking up from anesthesia. Patients undergoing diagnostic tests and procedures for pre-existing abnormalities before surgery. As a preoperative nurse, you will coordinate the completion of tests and verify that a patient is properly prepared. The patient's medical history, physical assessment findings, and surgical procedures determine the type of test ordered. Patients undergoing elective surgery and who may need blood products will need a pre-transfusion type and screen sample taken 1 to 7 days before surgery. This test ensures blood compatibility if a transfusion is needed and avoids antibodies that may emerge in response to exposure through transfusions or a patient's disease. Commonly, autotransfusion, which is the reinfusion of a patient's own blood supply, is more common today. Cluster the patterns of defining characteristics from your assessment to identify nursing diagnoses relevant for a surgical patient. A patient with pre-existing health problems is likely to have a variety of risk diagnoses. The nature of the surgery and the assessment of the patient's health status provide defining characteristics and risk factors for a number of nursing diagnoses. The related factors for each diagnosis establish directions for nursing care that is provided during one or all surgical phases. Preoperative nursing diagnoses allow nursing staff to take precautions and actions so care provided during the intraoperative and postoperative phases is consistent with the patient's needs. Nursing diagnoses made before surgery also focus on the potential risks a patient may face after surgery. Preventative care is essential to manage the surgical patient effectively. During planning, synthesize information to establish a plan of care based on the patient's nursing diagnoses. Apply critical thinking in the selection of nursing interventions. Critical thinking ensures that a patient's plan of care integrates knowledge, previous experiences, critical thinking attitudes, and established standards of care. Previous experience in caring for surgical patients help establish approaches to patient care. Professional standards are especially important to consider when selecting interventions for the nursing plan of care. These standards often utilize evidence-based guidelines for preferred nursing interventions. Successful planning requires a patient-centered approach involving the surgical patient and family to set realistic expectations for care. Early involvement of the patient and a family caregiver when developing the surgical care plan minimize surgical risks and postoperative complications and improve transition of care through discharge. A patient informed about the planned surgical experience is less likely to be fearful and is better able to participate in the postoperative recovery phase, so expected outcomes are met. Establish diagnosis, interventions, and outcomes to ensure recovery or maintenance of the preoperative state. Base the goals and outcomes of care on the individualized nursing diagnoses. Review and modify the plan during the intraoperative and postoperative periods. Outcomes established for each goal of care provide measurable evidence to gauge the patient's progress towards meeting stated goals. Use clinical judgment to prioritize nursing diagnoses and interventions based on the unique needs of each patient. Patients requiring emergency surgery often experience changes in their physiological status and that require urgent reprioritizations. Ensure that the approach to each patient is thorough and reflects an understanding of the implications of the patient's age, physical and psychological health, educational level, cultural and religious practices, and stated or written wishes concerning advanced medical directives. For patients having ambulatory surgery, those admitted the day of their surgery, and those with special issues, the healthcare team must collaborate to ensure continuity of care. Preoperative planning ideally occurs days before admission to the hospital surgical center. The collaboration between the healthcare provider's office and the surgical center is crucial to preparing a patient for a procedure and ensuring the proper equipment supplies are available. Preoperative instruction gives patients time to think about their surgical experience, make necessary physical preparations, and ask questions about postoperative procedures. The patient having ambulatory surgery usually returns home on the day of surgery. Thus, well-planned preoperative care ensures that the patient is well informed and be able to be an active participant during recovery. The family or significant other plays an active, supportive role for the patient. Except in emergencies, surgery cannot be legally or ethically performed until a patient fully understands the surgical procedure and all implications. Surgical procedures should not be performed without documentation of the patient's consent in the medical record. Chapter 23 discusses in detail the nurse's responsibility for informed consent. It is the surgeon's responsibility to explain the procedure, associated risks, benefits, alternatives, and possible complications before obtaining the patient's oral and documented informed consent. The patient also must be informed about who will perform the procedure. To ensure that a patient understands information about surgery, the Joint Commission recommends consent materials be written at a 5th grade or lower reading level. After the patient or power of attorney signs the consent form, place it in the medical record. The record goes to the OR with the patient. As a nurse, if you have any concerns about the adequacy of a patient's understanding of surgery, report any concerns to the operating surgeon or anesthesia provider. Although patients can now access their medical records electronically, confidentiality risks still exist. Inappropriate discussions of a patient in any planned surgery in elevators, cafeterias, or in social settings after work can end up being communicated worldwide. You have an obligation to protect each patient's privacy by avoiding inappropriate discussions and not using social media to convey information. Posting patient information and photos on websites is prohibited in 26 state boards of nursing, and they have taken disciplinary action against nurses who practice such behavior. In addition, you might be violating federal and state patient privacy laws. Health promotion activities during the preoperative phase focus on health maintenance, patient safety, prevention of complications, and anticipation of continual need after surgery. Patient education is an important aspect of a patient's surgical experience. Patient education also reduces patients' preoperative anxiety, which can lead to an increase in post-op pain, poor outcomes, and prolonged hospital stays. Preoperative information and instructions are delivered by telephone calls and home mailings from healthcare providers' offices. When a patient is scheduled for surgery, whether outpatient or inpatient, pre-admission nurses call patients up to a week before surgery to clarify questions and reinforce explanations. When giving a rationale for pre-op and post-op procedures, patients are better prepared to participate in their care. Patients who undergo ambulatory surgery need to learn how their instructions and exercises will promote recovery, prevent complications, and allow them to return to a normal lifestyle as soon as possible. Patients who undergo inpatient surgery need to understand what is required to facilitate their recovery, including pain control, activity level, diet progression, wound care, and the need to be able to perform post-op exercises which can prevent pulmonary and vascular complications. Explain the preoperative routines that a patient will undergo. Knowing which tests and procedures are planned and why increases the patient's sense of control. After the surgeon explains the basic purpose of a surgical procedure and its steps, some patients ask you additional questions. First, clarify with the patient what was discussed with the surgeon. If a patient has little or no understanding about the surgery, notify the surgeon that the patient requires further explanation. Avoid saying anything that contradicts the surgeon's explanation. You can augment the surgeon's explanation. Emphasize that the scheduled time is a rough estimate and the actual time can be sooner or later. Make the family aware that delays do not necessarily indicate a problem, and always make sure that you communicate excessive delays when they occur. Few patients are admitted to a hospital unit prior to surgery unless their case is emergent or a complication develops during their hospitalization. When surgery is elective, patients and families will come to the surgical center admission area. There, the patient will learn that likely unit he or she will be on following the recovery. The family needs to know where the patient will be after surgery. Be sure to explain where the family can wait and where the surgeon will attempt to find family members after surgery. Many institutions have programs where the circulating nurse gives periodic reports to the family in the waiting room for surgeries that are expected to be prolonged. If patients understand the type and frequency of anticipated monitoring and procedures, they are less apprehensive when nurses perform care activities. Provide patients with information about the sensations typically experienced after surgery. Preparatory information helps them anticipate the steps of a procedure and thus form realistic images of the surgical experience. Postoperative sensations to describe include blurred vision from ophthalmic ointment in the eyes, expected pain at the surgical site, and in areas of the body affected by prolonged positioning, the tightness of dressings, dryness of the mouth, sensation of a sore throat from the endotracheal or breathing tube. The type of surgery that patients undergo determines how quickly they can resume normal activities and regular eating habits. It is normal in most surgical cases for patients to progress gradually in activity and eating. Inform the patient and family of the need to manage pain so patients can resume activity and the type of therapies likely to be used for pain relief. PCAs, or patient-controlled analgesias, is common and provides patients with control over pain. Explain and demonstrate to a patient how to operate a pump and the importance of administering medications as soon as pain becomes persistent. Pain relief has been shown to be more effective when analgesics are given around the clock rather than as needed. Rest is essential for normal healing. Meet each patient's individual needs. Give them time to ask questions so that anxiety can be minimized. If the patient is in the hospital, make the environment quiet and comfortable. Some patients feel like part of an assembly line before surgery. Frequent visits by staff, diagnostic testing, and physical preparation for surgery consumes time, and the patient has few opportunities to reflect on the experience. Recognize the patient as a unique individual. Acute care activities in the preoperative phase focus on the physical preparation of a patient on the morning of surgery or prior to an emergent surgery. A surgical site infection is one of the National Quality Forum endorsed patient safety measures that hospitals are encouraged to report. CMS, or Medicare and Medicaid, no longer pay a higher reimbursement for hospitalizations complicated by certain types of surgical site infections if they were not present on admission. As a result, there is a greater emphasis within hospitals for preventing the occurrence of SSIs. Antibiotics may be ordered in the preoperative period. A reduction in wound infection rates occur when an antibiotic is administered 60 minutes before the surgical incision is made, and the antibiotics are stopped within 24 hours after surgery. Preoperative care involves skin antisepsis to reduce the risk of a patient developing a surgical site infection, or SSI, by removing soil and transient microorganisms at the surgical site. Current evidence supports leaving hair at the surgical site in place under the hair interferes with exposure. Closure or dressing of the surgical site. When hair removal is required, clipping the hair is likely to result in less SSIs than removal with a razor. A surgical patient is vulnerable to fluid and electrolyte imbalances as a result of the stress of surgery, inadequate preoperative intake, and the potential for excessive fluid losses during surgery. The American Society of Anesthesiologists has recommended on fluid and food intake before non-emergency procedures requiring general and regional anesthesia or sedation. These recommendations include fasting from intake of clear liquids for 2 or more hours, breast milk for 4 hours, formula and non-human milk for 6 hours, and a light meal of toast and clear liquids for 6 hours. A patient also cannot have any meat or fried foods 8 hours before surgery, unless explicitly specified by the anesthesiologist or surgeon. Despite the ASA standards, many surgeons still have patients maintain nothing by mouth after midnight. Ensure that you follow the healthcare provider's orders. Notify the surgeon and anesthesia provider if the patient eats or drinks during the fasting period. If a patient cannot eat because of GI alterations or impairment in consciousness, you will probably start an IV route for fluid replacement. Patients with severe nutritional imbalance sometimes require supplements with concentrated protein and glucose, such as TPN or total parental nutrition, which is in the form of an IV. Some patients receive a bowel preparation, such as an enema, if the surgery involves the lower GI system. An empty bowel reduces risk of injury to the intestines and minimizes contamination of the operative wound. If colon surgery is planned, or a portion of the bowel is incised or opened accidentally. In addition, Cleansing of the bowel reduces postoperative constipation. Too many enemas given over a short time can cause serious fluid and electrolyte imbalances. Most agencies limit the number of enemas, typically to 3, that a nurse may administer successfully.